We know that because of pandemic and because of work pressures afterwards, we're generally a little behind with a lot of our chronic disease reviews and routine monitoring. It's worth saying that some of that had deteriorated when you look at national audits from contract changes in 2016. So, for example, when we look at our contract searches, things like stroke, we used to have a search that would make sure we were monitoring blood pressures, lipids, antiplatelets, and smoking status. And those searches disappeared when the contract effectively deactivated some of those QOF indicators. We also lost the prompts, the little alerts that were coming up in the bottom right. If we were seeing these patients and they weren't on lipid lowering or they weren't on antiplatelet medication, it would tell us, but we lost that. Now in 2016, the Anglesey cluster was looking at how we were monitoring medications, and specifically at that time how we were monitoring shared care medications. There was quite a lot of admin work involved and frustration that patients might be seen but might not always get all the testing they needed. And so we developed alerts and prompts, not dissimilar to the EMIS ones at the time, but we went one step further. So rather than having an individual protocol for each individual drug, we devised an alert simply to say, right, this person needs some sort of testing, and we'd highlight if it was shared care testing. And if we clicked on that alert, it would take us to a template using all sorts of concepts and visibility rules to make sure that all the tests that patient needs are shown in one template. So for example, this patient, our alerts would say, hey, there's shared care testing due. You can't see these because there's a name at the top of the box and that needs to be at the screen. If you hover over this, it tells you this patient's on methotrexate. And if we look down below, you can see our templates, HCA and nurse templates. So if I double click on the shared care testing due, the template looks at this patient's medications and pulls together all the tests they need. It also pulls together processes related to chronic disease and QOF. So for example, this patient this year, there's an emphasis on unhealthy lifestyles, making sure that we monitor those or at least record those in our chronic disease patients, and also code if we have signposted treatments or referred them. And we can see that this patient needs, yes, their alcohol weight and smoking status. They also need their ACR, and that's because they've got a little bit of CKD. They also need their LFTs 3 monthly for the methotrexate. And you can see it also shows if something's up to date already. So unfortunately, this patient has been in on the 6th of March. And yes, they've had their UNEs, full blood count, thyroid, lipids, CRP done. They didn't have their LFTs and folate done. The idea is we're showing things that are already done so that we can perhaps reconcile their testing. But unfortunately, what you find is people just ignore prompts and alerts, particularly clinicians if they're focusing on an acute presentation or they've been booked in for a specific task or process. And we've done similar work over the years, particularly around the QAF and the contract, so that we'd highlight if people had high-risk medications, we'd have nice big alerts and pop-ups in the same fashion. And again, these are just being ignored. So we decided at cluster level that really for a lot of these things we need to look at a better and more robust recall system. Now the way we've run a lot of our recall systems in the past is that we might run searches for various diary codes, we might run searches for various medications, we might run searches for various problems and issues and have several searches running. Really what we want is simply to be able to say we need a person to come in to see a health carer if they've got basic processes, or straight to a nurse if they're up to date for the processes but they need their chronic disease review. The issue with running several searches from several sources is that we'll get the same patients coming up on all sorts of different lists, being invited to all sorts of different clinicians, different time of the years. We want to streamline this so that anybody that needs a basic process gets invited to a health carer, and that when they see the health carer, we know they've got a template that shows everything that patient could possibly need. One of the things we looked at for our diabetes enhanced care was the concept of a year of care process. So this is one where a patient might be invited to see the health carer first, have all their processes done, then be sent a summary or a results list, and be invited in for the nurse for the chronic disease. The idea is then the nurse isn't doing simple processes, but can spend that review actually doing a good holistic review. We don't want patients turning up for review, just be told, you need a series of tests and we'll see you again afterwards. That's just repeated appointments that's wasting everyone's time. And again, so we want one healthcare appointment and we just want the one nurse appointment. We do not want repeated appointments. The other thing that we want to look at is trying to structure our medication reviews so that when a clinician is looking at a list of medications, that all the processes related to that medication are done ready for that. We do not want clinicians, particularly any senior clinicians, looking at a list of medications, simply saying, right, bring them in for this test, that test. That's wasting their time. Those things should be ready for the review. And ideally, perhaps any chronic disease done before any review, so that you've had all the information in front of you and hopefully you can just reauthorize for a year. So how do we do that? So what we've done is, rather than having lots of searches and lots of lists, we've merged all our searches together. So people for any sort of medication or any process, any chronic disease process, it's simply pulling them all into lists of processes and then pulling them all into one search. So for example, here, the HCA search. Now, we know that we're quite behind, that we can't cope with trying to catch up with everything at once. We also want to have this structured approach where we say, right, in for the health carer first, then the nurse, and then a review of their medications. And we think the way to do that is to invite people by month of birth, so that we're spreading any workload out over a 12-month period. And we know then we can say, right, in the month of your birth, we'll invite them in for health carer first. We can then say, right, invite people born a month ago to see the nurse, and then arrange for a search to look for people born 2 months ago for any type of medication review. The idea being is that once we've got this up and running, we know that we've got a structured approach that means that we have this stepped year of care model. Now, clearly, not all things fall annually. So things like shared care need to be done more frequently. Some of our other medications, or CKD or DOAG in particular, might need doing a little more frequently than yearly. So we would still pull these patients in when their processes or tests are due. These searches only look for patients who need something right now. So if, for example, somebody's born in April but everything's already up to date, we're not inviting them again. We don't want to create more work. We've also split this group of patients into groups that might need more or less clinical time and have different types of prioritization. So diabetic patients, I'd like our health carers to do an awful lot more with those, so they might need a longer appointment. Shared care have a certain priority because there is a contractual financial target for these. Our frequent but not shared care group, again, we're calling them in separately because that's not an annual check. And then we've got our patients who just need an annual check. Now, part of the reason for splitting these up is also if we are looking at some sort of cluster, hub or community support, I'd suggest the practices prioritise the higher risk ABC groups, but we could look at sending Group D outside or having support for those externally. Not all of our routine annual checks need a blood test. So if we've got patients born in April who need a blood pressure but no blood test, they fall into this group. The idea being that we might be able to just text them and ask them to input their blood pressure and have it come back directly into our records if we've got a nice system to do that. Or suggest that they go to a chemist or have their blood pressure done in automated machines in our waiting rooms. Ideally, I don't want these people immediately being booked in with a clinician. These numbers are a lot higher than usual at the moment because of pandemic and because of changes in contracts. And I think trying to get them all in at once would overwhelm our appointments and capacity. Again, we have spread them by month of birth just to help to smooth out that workload. And we're separating this group off because we think we can manage these without making appointments with clinicians for them. Now, the other area that concerned us was, are we chasing targets aggressively enough in some of our patient groups? So this search here is not a month of birth search. This is simply looking for diabetic patients whose last HbA1c was not to target, so it was over 60 is the target we're using here. It's been at least 4 months. We're assuming that a raised result's been seen, that somebody's done something about that, and then 4 months later we want to chase that up. Now, we know some practices use the diary for this, and I'll come back to the diary, but what we know is that a lot of these do slip the net, and there's a risk that patients become a bit complacent if we're not chasing them. So if we're not chasing patients every 4 months after an abnormal result, say, right, you're not to target, then they'll tend to think, right, everything must be okay, the practice isn't chasing me. And we've got a similar search for our blood pressures that aren't to target. We're using 150/90 just as a broad target for these. The difference with blood pressure is that some of these patients are already on medication. So they simply need their blood pressure checking, and if it's still raised, then we need to be titrating them to target. A large proportion of these are patients who aren't on medications, where we might simply be saying, right, let's just check you again in 3 or 4 months. Although they are a group where we could consider home blood pressure monitoring for the lot of them to really try and decide whether they need treating or not. The reason I've put these in a separate search is, again, we could look at support for practices to help arrange home blood pressure monitoring for these patients. These aren't divided by month of birth. These are simply at the moment our blood pressure people who aren't to target. Now, for the sake of catch-up, we've also run a search for spirometry. This is looking for 2 main groups. This is looking for people who've been diagnosed with COPD or asthma where there is no evidence of spirometry or reversibility coded. The trouble there is they might have had it done, but it's not been coded. The other group are patients taking preventer or steroid inhalers, particularly where there isn't a diagnosis of asthma or COPD, because those patients won't come under any sort of chronic disease recall. Again, this is a group where we have split them by month of birth. So I guess we've got 16 born in April that should have spirometry. It might be useful to do a desktop review to see if there has been any investigation done but not coded. But at the same time, it probably doesn't hurt to simply say, right, let's look at how we're doing spirometry. And I like the idea of a community hub, because this is a group that needs testing. And then I mentioned diary. Now, our diary search works slightly differently. We have a system where most of us have to run a whole host of searches looking for specific diary codes that our practices use as a way of reminding them to invite people back. Now, the trouble with that is that means that we're limited to a certain number of codes that we know we're going to search for. That means that there's people that might put the code in incorrectly and we don't have a search that picks it up. It also means that we lose a lot of functionality. I'd like to be able to put whatever we want into the diary and know that when it comes to that month, that it'll show it for us. Now, we've excluded medication reviews and chronic disease review diary codes here because we're calling these people in now with this month of birth structure. But it means that we then get a list of things that are due this month. And if I click view results on here, and what you can see is at the moment I've only got 15 patients here, but I anticipate us perhaps using the diary more readily if we know we can put whatever we like in here. So I know that we've got searches that look for blood test due and bone density scan. I'm not sure we've got a search that's going to pick up thyroid function test or liver function test. I'm pretty sure we've got searches for insertion of hormone implant and intramuscular injection of testosterone. The risk is if somebody in the follow-up has put the wrong code, these searches are not going to be picking that up. Now, our nurse recall groups are split a little bit by chronic disease. So if somebody's diabetic, I will be inviting people in April born in March on the basis that they'll have seen the HCA in March, hopefully, and had all the basic processes done ready. And likewise, similarly for the respiratory and other nurse chronic disease reviews. Now, I have separated off diabetes and respiratory because often people might have a nurse with a specific interest. And then the other chronic disease groups I've split into general cardiac, dementia, gender dysphoria, learning disability. Now, if a patient has diabetes and heart disease, they come under the diabetes nurse review. They don't show twice. Part of the reason behind that is that I know that our diabetic reviews are going to take a lot longer, and so we don't want somebody with heart disease suddenly turning up for a nurse review and not realising they were diabetic and not having a nice long appointment for them. But often some of these will be relatively quick in comparison. I guess it's possible that a nurse might say, right, I want to invite them back a second time. But the idea is we're trying to invite according to what's likely to be the longest appointment first. It's at this stage we should look at how we're doing the invites. And I guess telephoning is staff time, posting is expensive. I think it is useful to look at text, and I'd really love to have a system that allowed patients to book their own appointments back from texts. The difference might be if we're looking at the Eurocare model where we want to send patients their results in advance of an appointment. And this is where we might use a mail merge. You can't see the top of the screen. But if we mail merge this list, it's an old search, but don't worry about that. When we're doing the mail merge, I might say, right, I want to invite our diabetes nurse review. And you can see here that it allows you to say save in patient record, chronic disease monitoring first recall. So when you're creating that document, it's important that you have that document type as a recall invite code and click save in patient record. I won't here because we're not going to invite them today as such. But that's going to create the documents. And this is just a proof of concepts. It's a relatively simple document that just tells the patient, hey, we'd like to invite you in. These are your latest results ready for the year of care review. And I have left in here a more complicated list search. This is part of a separate project to extract data out, put it into a fancy spreadsheet and mail merge a more personalised invite that would look a little bit like this. So this is a little more fancy and it's a work in progress, but the idea is we can have a nice little letter that sort of picks up people's latest indices, tells them a little bit about their own conditions, their own issues, advises them what local resources are available for them, picks up if there's anything like, say, some of the QAFE safety concerns, tells the patient what tests they should have every year. The reason I'm showing this is just to sort of show that we can actually do quite a lot more with mail merging if we extract that information out of EMIS and play with it. Unfortunately, there is a bit of a limit on how big an extract EMIS will allow, and I think at the moment I would stick with simple merge documents from within EMIS itself. But make sure that any invite has that read code on it. The reason for that is that we want to look for people who haven't responded to any invites in the past month, so it looks to see if there have been any appointments or consultations, and we might invite them again. And then we want a search that picks up people who haven't responded to 2 invites. We also highlight anybody due a smear that doesn't appear to have an appointment booked already. And we've got a search that looks for people by birth month that are very overdue their smears if we are looking at catch-up in that area. We have a search that looks for our patients who are due a review of their anticoagulation, and this search would look to make sure that their bloods are up to date, ready for that review, be it desktop, telephone or face-to-face. If somebody is due their 6 months DOAG review and hasn't had their blood tests done, they would be in our HCA search and ready to have that review done after they've had their blood tests, just to try and avoid us wasting clinician time. The next search is based on a QI project that we did with some students from Bangor University, where it looks for patients on a DOAG where the dose may be a little incorrect for their indices. I'll show you an example of this one. So we can see there's a little flag that comes up to say, please review the dose of NOAG, possible concern. And you see that our alert, and this is EMIS's one, which is very good as well, but our alert saying, please review the dose. And that's because we think they might not be correct for that patient. And I'll go into that template. Now, this is quite a complex template because it's the template that looks for everything for the nurse. So this is saying this patient's eligible for pneumococcal, please give it. It has a COPD review, an emphasis on the Wales COPD guideline, COPD hub. It's suggesting at least that we should tick annual review because that's not being done. MRC, if I keep going, it's highlighting for this year's QIF project that this patient is on 4 or more SABAs a year, and it's saying, hey, should we consider MART therapy? And it's got the link to the Green Inhaler project. Again, no spirometry coded for this patient, so we might want our nurse to check that. Then they're on MDI inhalers. So again, it's saying consider a DPI inhaler for the project. It's highlighting this patient's had 4 courses of steroids in the past year, 5 courses of antibiotics, suggesting we might want to do a Q risk for them for their fracture score. They're on the stroke register. For this, it's got links to some of the advice on how to do a stroke review. Again, heart disease register, the heart failure register with links to the heart care plan and nice guidance on heart failure. It's mentioning that they're not on an ACE or an ARB, they're on the AF register, and then we're down to the NOAG review, and it's suggesting here that this person's on a DOAC with creatinine clearance of under 15, and that we might want to consider stopping warfarin. Most of these people would be under the care of the renal team anyway, but it's no bad thing to highlight it. And of course, just the HAS-BLED scores. Again, we've added in a few little things around how to code CKD properly. So for example, this patient, we know their EGFR they are G5A1. They are high risk. It's got links to the kidney failure risk equation. It highlights if a patient's pre-diabetic, so I know that this patient would have their HbA1c done when they come in for their blood tests. It's got links to Let's Prevent Diabetes Wales, and we can code to say they've had that diabetes prevention. It's emphasising health and well-being courses because of the various health problems. And again, emphasising we need their smoking, alcohol. At the bottom, it's got the list of processes I'd expect to have done ready for a review done by our HCA. And you can see that it shows them again, so the nurse would know if anything is overdue. Quite a complex example patient, but useful to get an idea of perhaps the power of the template in highlighting the various issues that we should be looking at for that patient. We've got our patients that are on high-risk medication. Now, these aren't going to be called in by month of birth. This is looking at all times for the high-risk medications that we were working on for QAIF. The cluster felt that the prompts and alerts were lovely, but everybody ignored them. So at least once a month, we want somebody to run through some of these. So I'll show an example of this as well. So again, a nice little alert telling us this patient needs shared care medication test and that they have a QAIF medication safety concern. It's telling us that their shared care testing is due, and if we hover over that, it'll say it's because of their methotrexate. It's telling us, and you can't see the box because I'm hovering, but this person is on anti-inflammatories with an EGFR under 60. It's mentioning the fact that on steroid inhalers with no diagnosis, so that I know that that monthly pickup would eventually pick up this patient. And then if I double click the Quafe medication safety box, as part of the nurse template, it would highlight that this anti-inflammatory is EGFR in the 60. Now, if we're happy with this, we just need to tick regular monitoring discussed with the patient, and that'll take them out of the search for the year. You might want to say why you're happy with that there. Again, it's an example of the nurse template where we're saying they're due with shingles, please give. Consider stopping their anti-inflammatory, really. Steroid inhaler, but no diagnosis. Now, I know that these will get gradually picked up, but you might want to consider referring or arranging spirometry reversibility. Again, it's highlighting 3 or more steroids. This person has CKD, but it's not coded. We haven't got an ACR. They're on the rheumatoid arthritis register, so we want their Q fracture. They're pre-diabetic, so again, it's suggesting that we give them Let's Prevent Wales. They didn't respond to their bowel screening, or at least we haven't got a code saying that. They're eligible for courses. Again, all these things have links. So if I click on this, it'll show you the link to health and wellbeing courses, so you can organise that for the patient. Because they're CKD, they need an ACR, and it's telling you that they need their UNEs, full blood count, LFTs, folate. They're up to date for their CRP. Their weight has been done, and their blood pressure has been done. Now, the routine medication review search, and I mentioned this earlier, this looks at patients born 2 months ago. So if this is the April search, these are patients born in February on 4 or more medications that will hopefully have seen a healthcare and had all their basic processes done. They will also have had a chronic disease review if it's relevant and had that done last month. So this month, this group of patients, when it comes to reviewing them, the hope is that we can perhaps get away with a desktop review or maybe a phone call, and that we can reauthorize these for a year. I like the idea of trying to bring our medication reviews into a slightly more structured, regulated process, so that again we're not just wasting clinician time saying, get such and such done. The searches at the bottom around managing non-responders and chasing non-responders. And then we've also got a couple of searches that again is looking for patients born 2 months ago who are eligible for pneumococcal or shingles. Now, hopefully these patients have been in through the nurse for their chronic disease reviews. There were problems with pneumococcal supply, and obviously with some of these things have not been possible to do remotely during COVID. Now, if they've been in for the nurse and had their jabs, then great, they won't show on this list. But if they have managed to slip the net, then there's just a catch-up for pneumococcals and shingles as well.